us today's session. Don't delay. Let's start early. I'm a urologist from University of Malaya. I'd like to start by expressing my heartfelt thanks to Medtric Mai for inviting me. It's truly an honor to be here with you tonight. Over the next few minutes, we'll be diving into benign prostate hyperplasia or BPH. Let's see what is it, why it happens, and how it presents. And I would like to introduce some latest approaches which we use to manage BPH. So let's get started. This is my disclosure for today's presentation. I'm sure many of us here can relate to this because it is a very common presentation that we see in our daily clinics. An elderly gentleman, maybe 50 years or older, come in with lower urinary tract symptoms. He might complain of a weak stream urine, having to strain to pass urine, frequent urination during the day or even at night, a sensation of incomplete emptying with sudden urges at times to urinate or needing to rush to the toilet most of the time. Sometimes he may even experience some urinary leakage if he cannot reach to the toilet in time. Or perhaps the most bothersome symptoms of them all are usually waking up many times at night, needing to urinate. A comprehensive systematic analysis from Global Burden of Disease Study in 2019 has highlighted the prevalence of impact of BPH worldwide. The condition significantly affects quality of life and increase disability-adjusted life years or dailies in aging men. So what exactly is BPH? As we know, benign prostate hyperplasia is a non-cancerous enlargement of the prostate gland that is associated with lower urinary tract symptoms. It can be either voiding or storage symptoms. It is most common in men, as mentioned earlier by Lila, in men over age of 50. In fact, it's found more than 50% in men at this age group and even more than 90% in men above age of 85. As the prostate gradually enlarges, it can compress and narrow the urethra, leading to progressively worsening symptoms. In some cases, the enlargement can also affect the bladder, causing storage symptoms such as frequency, urgency, and nocturia. A study published in the British Journal of Urology International showed that previously unrecognized BPH can significantly affect daily activities, not only in older men, but also in younger individuals. This impact induces reduced productivity and negative effect on social well-being. One of the most common complaints we hear from our patients is poor sleep at night. They wake up frequently to urinate, leading to severe daytime fatigue, and often spend much of the daytime feeling tired or even napping. I recall one patient who told me he had to give up playing golf, not because of his swings, but because of the constant urgency and the fear of not making to the toilet in time. But the stress and inconvenience of always needing to find a toilet quickly eventually caught up to him and he decided to give up golfing. The exact cause of BPH remains unclear, but there are a few theories around it. Hormonal changes with aging leads to a relative increase in estrogen, which may stimulate prostate cell growth. Additionally, dihydrotestosterone or DHT, a metabolite of testosterone, accumulates in the prostate and promotes cellular proliferation. These factors may shift the balance of molecular control of prostate growth and cause cell proliferation and prostate enlargement. So what's the natural history of BPH if left untreated? In one study looking at the cause of untreated BPH in 107 men on watchful waiting, meaning no active treatment for up to 5 years, and they found that about 25% of men actually improved without any treatment, 30% might get worse, and 40% remain the same. Around 2% of these patients develop acute urinary retention, with 10% of them progress to needing surgical intervention. So for most men, symptoms remain stable over time, although a small proportion will progress to more serious complication. What are the risk factors that make men more likely to develop BPH? This includes aging, particularly from 40 years and older, family history of prostate enlargement, metabolic syndromes such as obesity, heart disease, and type 2 diabetes. And of course, lack of physical activity and erectile dysfunction has been shown to have close relation and association with BPH. Diagnosing BPH, as with other disease, start with taking a detailed medical history, usually focusing on when the symptoms begin, how long have they been presented, and how did they evolve over time, especially regarding their storage and voiding symptoms, which may or may not impact their quality of life. On physical examination, a digital rectal examination should be performed to assess the prostate. We should check whether the surface is smooth or nodular and estimating its size at the same time, while nodular prostate might be a warning sign for prostate cancer. A PSA test is recommended for symptomatic patient. If the PSA test is elevated, the patient should be referred to a urologist for further evaluation. Normally, this may include an MRI imaging, and if necessary, we might proceed with a prostate biopsy. A urine analysis is essential at first presentation to look out for any possibility for other causes of irritation, such as carcinoma in situ or bladder cancer. If available in your center or clinic, we will also recommend to perform a uroflowmetry to measure the flow of the urine as well as post-void residual urine to establish a baseline flow rate and bladder emptying efficiency before we start treatment. For imaging, an ultrasound of the kidney ureter bladder or KUB and prostate is recommended to look for possibility of bladder outlet obstruction, such as hydronephrosis, which can occur secondary to BPH, which means the patient might need more urgent intervention. IPSS is a useful adjunct when taking the patient history, which stands for International Prostate Symptom Score. This is a self-administered questionnaire where the patient reports both voiding and storage symptoms. It contains 7 questions plus 1 additional question on quality of life. The scoring works as 1 to 7 being mild, 8 to 19 suggestive of moderate symptoms, and 20 to 35 being severe symptoms. Very quick and easy. The patient has to recollect regarding the symptoms of the past 6 months, and we can use it to guide our treatment later. PSA is an indicator for patients who present with urinary tract symptoms, and it's an indicator for prostate cancer. Currently, guidelines recommend PSA testing for men over age 50, men from 45 years old with family history of prostate cancer, men with African descent over 45 years, although this is less relevant in our local context, and men carrying the BRCA gene, which is closely associated with breast cancer. If the PSA result is normal guidelines suggest follow-up every 2 years for men who were initially at risk or symptomatic, meaning men with PSA more than 1 nanogram per ml at age of 40 or men with PSA more than 2 at age of 60 years old. For patients with untreated BPH, we have to be aware to inform them. It is important to remember the possible complications. This can include acute urinary retention or AUR, chronic or prolonged urinary retention, hematuria, recurrent urinary tract symptoms, urinary tract infection, kidney disease, as well as bladder stone formation. So how do we treat BPH? Currently, medical therapy is usually the first-line approach, and the first group of medication we use are alpha blockers. Common alpha blockers available in the market now include alfuzosin, doxazosin, silodosin, tamsulosin, and terazosin, with silodosin being the newest of them. This drug works by blocking the alpha-1 adrenergic receptors in the prostate, relaxing the smooth muscle within the gland, and this allows urine to pass more easily through the urethra. They also help to relax the bladder neck muscle, which can improve irritative symptoms. Alpha blockers usually worked within 1 to 2 days. The fast acting of alpha blocker makes them the ideal option to be a first line drug for treating BPH. In the guideline, alpha blocker carries a grade A recommendations for patients with moderate and severe LUTs due to BPH. When starting a patient on alpha blocker, it's important to be aware of the possible side effects. Alpha blocker can cause first dose hypotension during the first intake of the medication, leading to dizziness, fainting, fatigue, and headache, all due to vasodilation and relaxation of the vascular smooth muscle. Sometimes reflex tachycardia may happen as a response to drop in blood pressure. These side effects are more common in older patients, increasing their risk of falls. To minimize this risk, this is the reason why we ask the patient to best take their first dose at night just before going to bed and subsequent doses. Alpha blocker can also cause sexual side effects, particularly retrograde ejaculation due to the relaxation of the bladder neck. Another important point is that alpha blocker may cause intraoperative floppy iris syndrome. This is a surgical complication that occurs during cataract surgery. While it's associated with alpha blockers, it's documented to be most prominent in tamsulosin use. So in patients with cataract who are planned for cataract surgery, it's important for them and for their ophthalmologists to be aware of the alpha blocker intake. So when deciding which alpha blocker to start for our patients, it's also important to consider the side effect profile. Tamsulosin, alpha-leucin, and silodosin have a lower potential to cause orthostatic hypotension and syncope because they are more selective for the alpha-1A receptor. However, due to this selectivity, tamsulosin and silodosin are more likely to cause retrograde ejaculation. Hence, which is the lesser of the evils? It depends on which group of patients. A younger group of patients might probably not prefer silodosin, but the elderly group of patients might prefer a silodosin, which has lower potential for orthostatic hypotension. However, we should also consider the dosing. As we know, silodosin has BD dosing group. For patients who has poor medication adherence or compliance, it may be better to start on medications with OD dosing. Next, we have the 5-alpha reductase inhibitors, or the 5-ARIs. This work by inhibiting the 5-alpha reductase enzyme, which reduce the conversion of testosterone to DHT in the prostate. Over time, this lead to a 15 to 25% reduction of prostate volume, which is documented to be achievable up to in about 6 months. So because of that, we usually tell our patients that they need to be compliant with the drug for at least 6 month duration before considering it to be not effective. And because of this slow onset, 5-ARI are not usually used as first-line monotherapy, but usually as an add-on or combination therapy with alpha blocker. Currently, there are 2 5-ARIs in the market, as we know. They are the finasteride, which comes in a 5 milligrams daily dose, and dutasteride, which comes in a 0.5 milligrams daily dose. They differ slightly in that finasteride selectively inhibits the type 2 isozyme, where dutasteride inhibits both type 1 and type 2. This difference leads to that dutasteride to have a greater reduction in prostate tissue of up to 94% compared to finasteride, which have reduction of 80%. The serum half-life also differs slightly. Finasteride has 6 to 8 hours and dutasteride has up to 5 weeks. This is important because 5-ARI is meant a possible complication for 5-ARI is erectile dysfunction. Therefore, before starting patients on 5-ARI, we should always counsel them about their risk of sexual dysfunction and assess if they are sexually active before starting on this drug. Now, combination therapy with alpha blocker and 5-ARI is recommended for patients who are at higher risk of BPH progression. The predictor of progressions are well described in our landmark Olmsted County study, which includes prostate volume greater than 30 mils, increasing age, post-void residual urinary flow of less than 12 mil per second, worsening symptom score, post-void residual urine or PVR of less than 50 mils, Qmax, maximum urinary flow of less than 12 mil per second, worsening symptoms, and a PSA greater than 1.4. Patients with these features are reported to be more likely to experience disease progression, and therefore these are good candidates to start on dual therapy upfront rather than starting on alpha blocker first and add on 5-ARI later. In this landmark, well-known combat trial, the authors show that combination therapy is more effective than monotherapy in reducing the risk of clinical progression of BPH. They also showed that combination therapy demonstrated significant greater symptom benefit on either monotherapy at 4 years. In this trial, combination therapy was superior to tamsulosin in reducing the risk of BPH surgery or acute urinary retention needing catheterization. Here we can see the chart from the combat trial. It shows that combination therapy achieved greater improvement in the IPSS score as well as the Qmax or maximum urinary flow rate compared to monotherapy. This benefit became noticeable as early as 3 to 6 months and continued to improve over time, reaching their peak at 48 months or 4 years. This sustained improvement highlights the long-term value of combination therapy in selected patients. As we know, we now have tadalafil 5 mg approved for the management of BPH. So, could we consider tadalafil 5 mg as a first-line option for BPH instead of an alpha blocker? Let's take a common patient profile. Normally, we have a 62-year-old man with lower urinary tract symptoms with moderate IPSS score of 14, who also has concurrent erectile dysfunction. However, he's not keen to start on an alpha blocker and a 5-ARI due to the concern of sexual dysfunction of both drugs. Let's take a look at this study, which compared the effect of tadalafil and silodosin when used as monotherapy for treatment of BPH. Now, when we looked at the result, tadalafil showed similar incidence of headache and nasal congestion compared to silodosin, but importantly, it did not cause any orthostatic hypotension or retrograde ejaculation. So, for patients who wish to avoid side effects of alpha blocker, particularly orthostatic hypotension as well as retrograde ejaculation, for those who are sexually active, tadalafil monotherapy become a very, very sensible choice. Evaluation of the efficacy of tadalafil in management of lower urinary tract symptoms secondary to BPH is well studied in this meta-analysis involving 5 studies of 436 patients, which compared the experimental arm, which is tadalafil, with the control, which is tamsulosin. The forest plot demonstrated similar efficacies favoring neither, shows that they are very similar in efficacies in treating patients and managing their IPSS scores. When used as a monotherapy, tadalafil, when compared to placebo, tadalafil has shown to provide meaningful improvement in lower urinary tract symptoms due to BPH, with effects noticeable as early as 4 weeks. It is worth noting that this onset is slightly slower than tamsulosin, which can show benefit within just a few days, within 72 hours actually. Nevertheless, tadalafil still act relatively quickly, with improvement evident from the first week and consistent sustained improvement over the period of 12 weeks time. For sexually active patients who are unwilling to accept sexual side effects associated with 5-ARI but progress on monotherapy, Is it possible to combine tadalafil with an alpha blocker? In this study, the combination of tadalafil plus silodosin was compared with monotherapy of each drug alone. The results showed that the combination therapy provides significant greater improvement in IPSS score compared to either monotherapy after 3 months. Most importantly, when we start the patient on, if we try to start our patient on combination tadalafil and alpha blocker, we need to determine whether the combination drug has an increased risk of orthostatic hypotension. So in this study, the combination therapy was compared with monotherapy to assess both efficacy and side effect profile. The results show a combination therapy did not lead to statistically significant increase in complications compared to the monotherapy arm, with the exception of higher incidence of retrograde ejaculation in the silodosin group. Crucially, orthostatic hypotension has no increase, and this shows that tadalafil as combination is as safe as silodosin monotherapy when treating patients with BPH. Next, I would like to draw your attention to a recent study published in the Journal of American Medical Association, American Journal of Medicine in March 2025, which is a leading journal with an impact factor of 5.7. In this large population-based study from the US, the author evaluated the potential benefit of PDI inhibitor on mortality, cardiovascular disease, and dementia of over 1 million patients with low urinary tract symptoms. This represents one of the most extensive investigations to date. The authors evaluate the two common PDE5 inhibitors. The patients were started on tadalafil 5 mg daily for patients with LUTS and tadalafil 20 mg PRN or sildenafil 100 mg PRN for ED versus no treatment at all for those patients, middle-aged men above 40 years old, diagnosed with ED or LUTS over a 3 years follow-up period. They assess risk of all-cause mortality, cardiovascular disease, especially myocardial infarction, stroke, and venous thromboembolism, as well as dementia. The outcome shows that tadalafil as well as sildenafil, both PDE5 inhibitor, reduces all-cause mortality and incidence of myocardial infarction, stroke, venous thromboembolism, and dementia across the board. So what are the potential mechanisms by which PDE5 inhibitor could offer cardiovascular benefit in patients started on daily tadalafil 5 mg? The proposed explanation is that PDE5 inhibitor slows the degradation of cGMP in smooth muscle, as we know, which lead to smooth muscle relaxation and improved blood flow, not just at the penis, but also at the heart, thereby enhance endothelial function. The author further postulate that the daily use of tadalafil to manage low urinary tract symptoms may also provide sustained long-term benefit to the cardiovascular system and potentially cognitive function. This could explain why tadalafil appears to have slight advantage over the sildenafil in the outcome measures. So now tadalafil 5 mg daily is not just a valid alternative to tamsulosin in starting patients with LUTS. It also shows close association in reduced MACE or major cardiovascular adverse events in patients diagnosed with LUTS or ED over a period of 3 years. Also importantly, ladies and gentlemen, it is crucial to recognize which patients should be referred to us urologists. These include patients who do not respond to medical therapy or those who decline oral medication and prefer surgical intervention. And of course, those who develop complications such as acute urinary retention, chronic or long-lasting urinary retention, hematuria, urinary tract infections, kidney damage, either AKI or CKD, and bladder stone formation secondary to stasis. Hence, when it comes to surgical treatment for BPH, my message is clear. Don't delay as well, refer us early. Timely referral to us to assess the patient before irreversible bladder damage, sets in can optimize their overall outcomes and bladder function for BPH management. As you can see in this management flow chart, based on the EAU guidelines, surgical intervention for male LUTs is recommended in three main situations. One, the patient with absolute indication for surgery, as mentioned earlier, those with complication from LUTs, such as AUR, renal impairment, urinary tract infection, bladder stone formation, and those patients who do not respond adequately to medical therapy despite optimal dosing and duration. Also, for those patients who decline medical therapy but are motivated to seek definitive active treatment option. As you can see, there are many treatment options available for treating BPH now. In today's rapidly advancing medical era, we now have minimal invasive surgical options in treating BPH. These treatments are particularly suited for men with prostate size less than 80 mils and those who are at high risk or unsuitable for major operation, and also individuals who wishes to preserve their sexual function, especially retrograde ejaculation. Currently available techniques includes Rezum, Urolith, iTind, and aquablation. In Malaysia, Rezum is the only option currently available on the market, although Urolith is currently undergoing registration and is expected to be available by end of this year. What is Rezum? Rezum is a minimal invasive water vapor thermal therapy for the prostate gland. It works by delivering high temperature water vapor directly into the prostate tissue through a specially designed needle. The thermal energy from the steam causes immediate cell death and apoptosis, leading to gradual shrinkage of the prostate over following weeks to up to 3 months. This treatment is typically performed as a day care procedure, can be under blocked or spinal, and it usually takes only about 15 minutes to complete. During the procedure, 4 to 6 targeted steam injections are delivered into different zones of the prostate, depending on the gland size and configuration. And following the procedure, the patient will require a urinary catheter for a few days to a week to treat post-treatment swelling or edema. Symptom improvement is often noticeable within 2 to 6 weeks, with continued improvement over 3 months as prostate tissue resorbs. In this study, the author performed MRI scans on patients who had undergone Rezum therapy at 1 week, 1 month, and 3 months post-procedure. The scan compared prostate measuring 39 mils and prostate measuring 89 mils. So a somewhat smallish prostate and a somewhat biggish prostate who undergo Rezum treatment. And they showed that up to 91% of the ablation lesions were successfully absorbed following Rezum treatment in a gradual onset of up to 3 months. In the landmark Rezum 2 study, a randomized controlled trial published in 2021, they reported 5 years data where IPSS decreased by 48% and Qmax improved by 49%, with only 4% of those patients needing secondary surgical retreatment. Therefore, Rezum can be considered a relatively safe procedure for patients, even those on antiplatelet therapy, due to its minimal invasive nature. It has been shown to reduce IPSS up to 48% and improve Qmax up to 49% as mentioned. Importantly, patients generally do not experience sexual dysfunction, so no ED and no retrograde ejaculation. However, they should be aware that the strict post-procedure precaution that they need to be on catheterization for at least up to a week before removing the catheter. The common side effects or risks of procedure which we explain to our patients are dysuria, hematuria, frequency, urgency, post-operatively, and acute urinary retention needing recatheterization. but these are usually mild and self-limiting adverse events. Next, we have Urolith. Urolith is a permanent implant, consists of two nitinol anchors connected by a non-absorbable suture. This system works by retracting the obstructed prostatic urethra through the prostatic capsule, thereby relieving the blockage. As I mentioned earlier, it's currently undergoing registration and will be available in our country at end of this year. As shown in this video, the Urolith system provides mechanical retraction to the prostate lock, opening up the prostatic urethra to allow easier urine flow. This procedure can even be performed under local or spinal anesthesia in a daycare or outpatient setting, but it's generally recommended for prostate gland with a volume less than 70 mils. As you can see here, the pathway opens up for the patient to urinate as compared to before treatment. So the evidence behind Urolith is this LIFT study, where they compared prostatic urolith for patients with associated BPH. They looked at 206 patients with a prostate size of 30 to 80 mils. They had a 5 years follow-up looking at quality of life as well as LUTs at 2 weeks, which was improved, and the author reported surgical retreatment rate at 5 years is at acceptable rate of 13.6%. This is mentioned acceptable because a 5-year retreatment rate for TURP, which is the gold standard, is about 10%. And at 5 years, up to 10% of the patient eventually will need to restart their oral therapy, either alpha blocker or a combination alpha blocker with ARI. The median lobe is excluded because there's some risk of puncturing the median lobe to the rectum for posterior puncture. So this evidence has led to recommendation of Urolith in our EAU guideline to be recommended for patients who are keen to preserve ejaculatory function for prostate volume less than 70 mils without the median lobe. I'll briefly mention about ITIN. ITIN is another minimal invasive mechanical temporarily implant, which was placed in the prostatic fossa, as seen in this video, via cystoscopy examination. This self-expandable implant is left in place for up to 3 to 5 days, during which it induces pressure necrosis at the prostatic fossa, resulting in permanent dilatation of the area to ensure better urine outflow. Aquabeam is a robotic system designed to perform hydrodissection. Aquabeam is a robotic system designed to perform hydrodissection of the prostate and is considered one of the least minimal invasive MIS option for BPH treatment. It consists of a CPU, a robotic handpiece as you've seen here, and a console. The procedure is typically performed under general or spinal anesthesia. After the transrectal ultrasound mapping of the prostate as seen earlier, the robotic system delivers a high-velocity water jet in a windshield wiper motion to reset the prostate tissue while sparing critical structures such as the bladder neck, the verumentanum, and the ejaculatory duct. Because the resection is performed without heat and only using water jet, it is associated with good preservation of sexual functions as well as urinary continence. However, sometimes a separate hemostasis procedure may be required due to bleeding. At present, Aquabeam is also not yet available in Malaysia. It is available in Singapore though. So after reviewing most of the available minimal invasive therapy, the data show that this option provides promising improvement in Qmax for patients with BPH, making them a viable alternative for those on dual medical therapy because they have somewhat more promising Qmax improvement. Therefore, they can be considered as a substitute for medical therapy in patients who are unable to tolerate or choose not to remain on medication. Of course, cost and availability are also very important considerations. TURP or transurethral resection of prostate, as we know, remains the gold standard for treatment of BPH. Having stood the test of time, it offers a reported improvement in Qmax of up to 162% and a 70% reduction in IPSS score improvement. When counseling patients, we usually inform them of the potential risks. The reintervention rate is approximately 2% per year due to prostate regrowth. So at 5 years, it's up to 10%. There's a small risk of bleeding of approximately 2%, and in less than 10% of the cases, there may be incidental detection of prostate cancer. Retrograde ejaculation occurs in about 80% of patients, as the procedure involves widely opening the bladder neck. There might also be a slight risk of ED of up to 5%, 5 to 10% in our patients. Looking again at the guidelines for BPH management, there's left with one enucleation technique can be done either using laser or bipolar energy that can be offered to our patient with prostate larger than 80 grams, or even documented to be safe for patients who are on anticoagulant or antiplatelet therapy. Holmium laser enucleation of prostate or HOLEP is one of the services I performed at University Malaya. It has essentially replaced the traditional open prostatectomy, allowing us to remove prostate from its capsule endourologically using a laser. In very simple terms, it's almost like carefully peeling off an orange from its skin. We separate the prostate from its capsule with laser precision. Studies have shown that HOLEP, when compared to TURP, offers several advantages. It is equivalent. It has got shorter catheterization time. We usually keep catheter for 1 day, then we'll remove the catheter and allow the patient home. Therefore, there will be shorter hospital stay as well. And there's ability to remove a much larger volume of tissue as compared to TURP. In 7 years long-term follow-up, the author demonstrated significant greater improvement in IPSS as well as Qmax for patients who underwent HOLEP as compared to the conventional TURP procedure. So for patients with large prostate, especially those who might otherwise need an open procedure, HOLEP offers a safe, effective, and durable solution. So if you encounter such cases in your practice, please do not hesitate to refer to us early so we can offer them benefit of this advanced treatment. With that, I would like to conclude my presentation for this evening. Thank you very much for your attention. I want to emphasize that don't wait too long to start early treatment. And if you know the patient would benefit for surgical therapy, do not hesitate to refer them early as well. On that note, I wish you a pleasant evening and thank you once again.
Thank you so much, Mr. Chai, for a very, a very wonderful presentation and also a very insightful and evidence-based presentation. So now we know for a male patient, elderly, with the risk, if the patient presented with lower urinary tract symptoms, think of BPH. We have to assess the patient and not only